Hello, doctors. Good evening. How are you all? I hope everyone doing well. Today we will do infectious disease parts, which I combined July and June topics together. And these topics are only came in July, and these topics only came in June. So they haven't been repeated. So only this part has been repeated in 2 months. So I prefer to do these topics most than the others because they are usually come in exam. So let's just start. So now we are only doing infectious this week, and tomorrow, not the day after tomorrow, we do infectious disease, and I'm planning to do ethics for 2 sessions. I know there is a lot of topics to discuss, but we are not able to finish. So let's do some topics of the infectious disease, but if we got some time, we will finish the pediatric. Okay, so the first topic is about the leptospirosis. Um, the general information about this is a zoonotic spirochete disease, which is caused by Leptospira interrogans, and that can be transmitted by animal urine contaminated or contaminated water or soil, or by the animal urine. And also, it is most common in tropical Australia, especially in people who are working in the farm. The definition is the organism which is very common is Leptospirosis interrogans, and the endemic area is Queensland Northern Territory, which is frequently associated with the food. The risk factor for leptospirosis is first the transmission, which transmission is usually happening by urine of infected animals, and also which is in pigs and livestock or rodents through the mucous membrane or broken skin. And the people who are farmers and they're also abattoirs workers, sewer workers, or veterinaries. So these people will be in the high risk. And also remember that kayaking, whitewater rafting, freshwater swimming also can be risk factors. Environmental risk factors are included recent flood exposure or heavy rainfall. So the clinical presentation is came in two phases. The phase one is septicemic, the phase two is immune or whale disease. In septicemic, the timing, the period, incubation period is from 1 to 7 days, and the patient will have sudden high fever, severe headache, severe myalgia, which is classically the coughs, and conjunctival suffusion, which the patient will have red eyes without purulent discharge. This is the main distinguishing from the viral and bacterial conjunctivitis. The patient have red eyes, but there is no purulent discharge. The phase two is immune or Wales disease, which can happen after day 7, and the patient will have jaundice with renal failure, which also the patient in the scenario will shows a high creatinine with hemorrhages. And also the patient will have meningitis pulmonary hemorrhages. Again, in phase 1, the patient only has high fever with severe headaches, severe myalgia, conjunctival problems, and in phase 2, jaundice with renal failure and hemorrhages. These three are the triad after day 7. So which investigations are very important? The first, which initial investigation is FBC, and we will check if there is any neutrophilic leukocytosis or thrombocytopenia, which is common in severe cases. And also we are checking LFT, which shows a high bilirubin level, and ALT moderately raised of the ALT and AST. UNE also elevated urea and creatinine, which is shows AKI as well. And in early first 7 days, we do PCR of the blood or CSF, and also we do blood culture in the special media. In the late phase after day 7, we always check the serology or urine PCR. Okay, so it is all the investigation. Now, management part is quite easy and short. In a mild disease, we are starting with oral doxy 100 milligrams twice for 5 to 7 days, or oral amoxi. For severe disease, we will admit the patient with IV antibiotics. The first line for the severe cases is IV benzoyl penicillin, which we are giving 1.2 grams 6 hourly, or we are giving IV ceftriaxone 1 to 2 grams daily. The supportive care is generally well given for the patients. We are starting IV fluid for the AKI problems and also monitor for respiratory distress, which if the patient has pulmonary hemorrhages. Mild disease, severe, first line of severe, supportive care. The next is important in CPL, the red eye. Always remember the red eye trigger. See if there is a febrile form of patient, but conjunctival sufficient. And also if they have a calf tenderness, think about leptospirosis. Incubation period, we mentioned 5 to 2 weeks is incubation period. The worst triad is jaundice, renal failure, and hemorrhages, which is the second phase. The flat flu in Queensland, Northern Australia, patients with fever after the flood, think about leptospirosis until proven otherwise. So there is some differential diagnosis with Q fever, brucellosis, hepatitis A, malarious, and malaria. So these were in the options of the leptospirosis question. So how we differentiate from Q fever? The patients will have fever. The patient will have cough, pneumonia, and also hepatitis. There is no jaundice or conjunctival sufficient. What investigation we do or management of Q fever? In phase 1 or 2, we check serology and we will treat with doxycycline. The AMC trap is choosing lepto when chest X-ray shows infiltrates, because this is a Q fever cases. If they give an X-ray and it shows infiltrates, think about the Q fever. Brucellosis is the patient will have indolent fever, night sweats, arthralgia, no pulmonary sign. The investigation of the brucellosis, we check blood culture in 3 weeks, and also the management is doxy with rifampicin. And for AMC trap, they remember that confusing livestock exposure, which is brucellosis in the pig and sheep, and leptospirosis will be in the rodent or water, contaminated water. Okay. So in brucellosis, the indolent fever is very highly pathognomonic and specific, which gradually the patient will have a gradual raise over several days of the fever, not sudden high fever. So this is the best differential between brucellosis and Hodgkin lymphoma. And malaria, remember, in malaria also, there is a differential between malaria and brucellosis. In malaria, there will be a periodic fever, which is sometimes it's high, sometimes it's down, but in brucellosis, it's indolent. Hepatitis A, the patient will have jaundice with right upper quadrant pain, young traveler, and no severe myalgia. So investigation management is anti-hepatitis A, immunoglobulin and supportive care only, and TRAP is missing travel to Thailand, Bali. The clue is hepatitis A. If there is any travel history, then think about hepatitis A. Malarious in Northern Territory or soil contact. INT, I don't know what is INT here. So if the patient is in contact with soil, and also if the patient has abscesses, severe respiratory distress, this can be the case of I was also thinking Northern Territory, but What's mean not respiratory contact? Okay, anyway. So the patient mostly have abscess, severe respiratory distress, and myelitis, and a high mortality. We are starting IV meropenem or ceftazidime. Okay, Dr. K. The AMC trap is, remember, missing risk factor like diabetic, mellitus, alcohol. I think this is not territory. Okay, anyway. Diabetic, mellitus, alcohol, and not territory, maybe. So these are the traps. If you miss this, like if these risk factors are not in the system, don't go with mellitus. Malaria case, in malaria, the cyclic fever, they will have a cyclic fever, as I said. Brucellosis and malaria, the differences between fever, different type of fever. Cyclic fever in malaria and splenomegaly travel to Africa. And the investigation is blood film, which is gold standard, and the AMC trap. Remember that every febrile African traveler think about malaria. Okay, so that was the general information about each of them, but I have all of them in the topics. We will clearly explain each of these topics. So the common AMC pitfall and traps, remember about the rodent trap. AMC will give you farmer, or they give you white water rafter or flat exposure, so not explicit rodent contact. The steroid trap, remember, do not give steroid for jaundice or renal failure. The management is antibiotic with supportive care. And the serology timing trap, remember, do not order serology in first 3 days because it will be false negative result. Use always PCR in early phase. Okay. So this part, it might be a bit confused for you. This part means that there shouldn't be if there in the stem say that not explicit rodent contact, don't go with the leptospirosis. Sorry, give me 1 second to think, not explicit rodent contact. Okay, so the rodent contact is always in the leptospirosis. If they are giving you white water after, or even blood exposure is also a risk factor for leptospirosis. But if the question didn't say the patient is not exposed to rodent contact, then it like rule out leptospirosis. Rodent contact, blood exposure is always the risk factor in the farmers as well. And now there is some must do and must not do. They ask about the livestock, rodent, or flat water contact. This should be, any of them should be in the scenario. Check urine and electrolyte and LFT to monitor for Wales disease. And consider pulmonary hemorrhage if short support or hemoptysis is there. Treat severe cases with IV benzalpenicillin or ceftriaxone. Do not do these off sentences. Means wait for jaundice before starting antibiotic if phase 1 features are present. This is wrong. Forget that leptospirosis is a notifiable disease in Australia. It is a notifiable disease. Exclude malaria in any febrile travelers from an endemic zones. Use aminoglycoside like gentamicin as a primary therapy for spirochetes. So these are all wrong and these are all correct. Now let's do some recalls and AMDC question, then our theory will make sense. A question came patient traveled to Africa for 1 month and returned 10 days ago, anorexia, lethargy, mild fever, jaundice, upper abdominal pain, loose stool, no muscle symptoms is there. What is the most likely diagnosis? Options are given as a malaria, leptospirosis, hepatitis A. As I previously said, if the patient has a travel history to Africa, okay, and mild fever, jaundice is there, so think about hepatitis A until proven otherwise. The explanation is says no myalgia rule out this leptospirosis. Jaundice with abdominal pain, loose stool, and traveler is hepatitis A. Malaria excluded because there is no splenomegaly in the scenario. The next recall came in March as a child returned from a trip with icterus or jaundice and diarrhea from the trip. No splenomegaly, mild tender hepatomegaly. What is the diagnosis? Hepatitis A, malaria, leptospirosis. This is the same options, but different stem. Again, we think about hepatitis A because of jaundice and because of hepatomegaly and travel history. The next question in June 25, as a 32-year-old abattoir worker, 2 weeks fever, headache, myalgia, dry cough, mild hepatomegaly, conjunctival diffusion absent. Most likely diagnosis: leptospirosis, Q fever, legionnaires, or hepatitis A. So here, some of these features are things we think about leptospirosis, but just conjunctival sufficient is not there. So we can rule out. But think about abattoir with dry cough, hepatitis, no conjunctival sufficient. This can be Q fever. And leptospirosis is ruled out by absence of red eye and no water and flood exposure. Okay, so remember the doctor says legionnaire. Legionnaire is always very common in older ages. This is very young. And also the patient will have some respiratory problems, like they have a history of smoking, they will have a COPD history, like they have some problems of breathing, and there is no 2 weeks of fever mentioned, that's okay. And the patient will have also dry cough, that's also okay for the legionnaire. And but there is no any respiratory problems. That's why we can rule out legionnaire in this case. Okay. Next, this is a summary again. Leptospirosis interrogations, the pathogen, and contaminated water, soil is the main route of the infection from the animal urine. Floods, banana forms, abattoirs. These are all high-risk people. The phase 1 sign is sudden high fever, headaches, intense cough, myalgia, and conjunctival sufficient, red eyes, no discharge. And in phase 2, the patient will have jaundice, renal failure, hemorrhage, which is Wills disease. The gold standard is the serology or leptospira immunoglobulin M, immunoglobulin G. In early cases, we do PCR. The first line mild case, we start oral toxi, and the first line for severe cases, IV benzodiazepine and ceftriaxone. Now some AMDC question. A 32-old abattoir worker, cut off sheep, 2 weeks fever, headaches, myalgia, dry cough, fine. Okay, so this is similar to previous recall, but more information. Dry cough, fine crackle, bilaterally, hepatomegaly, ALT 150, AC, NCLPD5, WBC is 12, most likely diagnosis. Leptospirosis, Q fever, Legionnaire, viral hepatitis mycoplasma. We say that it's Q fever because it's laboratory work, pneumonia, and hepatitis, and no conjunctival sufficient. So Q fever is very specific to diagnose. Occupational risk. This question, a 45-year-old with splashed with secretion from a sick horse with sudden fever. I think this is our veteriner, 45-year-old, and he's splashed with a secretion from a sick horse with sudden fever and respiratory distress. The horse is dead. So most at risk of developing is Hendra Leptospirosis, rabies, Q fever, or Australian bat Lisa virus. This is Hendra virus infection because horse with acute respiratory distress, rapid death in Queensland, New South Wales. It can be Hendra virus because lepto is produced by urine contaminated water, not respiratory secretion. This Hendra virus case, it's my first time I can see, but not came in recall, but to just remember that how to differentiate it from leptospirosis. The next recall immediate question: sheep farmer and consuming unpasteurized goat milk, undulating fever, joint pain, cervical lymphadenopathy, hepatosplenomegaly, and most likely causative organism Brucella, Bartonella hansenii, or Legionella, or Francisella tularensis, or Leptospira. So this is brucellosis because of undulant fever, as I mentioned, and unpasteurized diarrhea is in this scenario arthralgia, so brucellosis. Leptospira has an acute onset and need water, urine exposure, no risk factor is there. So that's why we can rule out easily. Now, a learning point, the transmission is contaminated water, soil, especially flat, or urine of infected animals like rodents, livestock, or pigs, with disease, pruritus, jaundice, renal failure, and hemorrhage, clinical conjunctival sufficient mass, and severe castellanasmalgia would be there. The testing early, we do PCR. For the after first week, we do serology. The treatment mild case doxy and severe case benzodiazepine. So I repeated this topics like 3-4 times. Now you like never forget it. And now there is some traps again. Farmer trap, remember, if there is a farmer with dry cough, high lifty, think about Q fever. If there is a farmer with red eye with renal failure, then think about leptospirosis. See, the renal failure is leptospirosis, and high lifty, liver problems and Q fever. Water trap, they are bringing a white water rafting, kayaking, or recent flood exposure. Think about leptospirosis. Animal trap, pigs, cattle, rodents, think about lepto. Sheep, goats with unpasteurized milk, think about brucellosis. Okay, is clear now? So once we do brucellosis, then you will understand the difference between these two. So now schistosomiasis, which came both in July and June. So we need to do this as well. So schistosomiasis, first of all, we should know that can cause by schistosoma pelad The transmission is by fresh water and penetrating the skin. And also remember about the sub-Saharan African migrants, refugee and travelers. These three groups are the most highest risk groups. So most commonly happen in these three groups. It is in recording, I believe. It is in recording, so I will post it on YouTube after session. Definition of schistosomiasis is the organism, as I said, it is schistosoma and a major cause of the morbidity in endemic region. And also this schistosomiasis is also called as a bilharzia. Sometimes you're bringing in options bilharzia. Remember that is schistosomia. The risk factor is first the transmission. The transmission, this pathogen can be penetrating the skin, and also while the patient is doing swimming, bathing, wading in the fresh water, and this pathogen can go inside the skin. Intermediate health specific freshwater snails requires for life cycle. Endemic region Sub-Saharan Africa, Somali, Egypt, Middle East, Southeast Asia, and South America. At risk in Australia, migrants, refugees, returning travelers, and routine health checks. These are in risk in Australia. So the clinical presentation in acute case, chronic case, in acute case, remember the swimmer itch, the patient will have an itchy popular rash at the cardial penetration site. Okay, swimmer itch in I'm just trying to show you the photos. So the photo is looking like this. Okay, so this is an itchy popular rash at cercarial penetration site. So the schistosomiasis is penetrated inside the skin, and it makes some swellings, inflammation, itchy papular rash. The next feature which the patient will have is Katayama fever. The patient will have fever, malaise, cough, and marked peripheral eosinophilia. In the chronic case, the patient will have urogenital problems like painless terminal hematuria, which is very classic, and dysuria, frequency, bladder wall thickening. Okay, very important. In chronic case, the patient has some urogenital problems like painless hematuria, dysuria, frequency, bladder wall thickening, and ultrasound. And the chronic, and also there is an intestinal or hepatosplenic problems as well. Like the patient will have abdominal pain, biliary diarrhea, hepatosplenomegaly, portal hypertension. So these are a chronic case too. What are the investigation? The first initial investigation is FPC to find out if there is any peripheral eosinophilia. Urine analysis we can do in the case of painless hematuria to detect the hematuria, even microscopy. Serology for the schistosomiasis serology preferred for asymptomatic people with eosinophilia and travel history. Microscopy, eggs and concentrated urine and imaging, X-ray, CT, KUV, they do, and they will check the bladder wall calcification and ultrasound bladder thickening, portal fibrosis. So the management is quite easy. Medical is the gold standard. They are giving praziquantel, which is the drug of choice, and surgery they do only if urinary catheterization for acute kidney injury from bladder outlet obstruction, or urology, ID referral for complication, bladder cancer, severe fibrosis. So this means if there is acute kidney injury from the bladder outlet obstruction, They will do urinary catheterization. And they will refer the patient to urology if there is any sign of complication, like if there is any bladder cancer or if there is any severe fibrosis, they will refer that to urologist. Okay, so the important points: Somali clue, young Somali refugee, painless hematuria. This AMC pairs is super high important because each of these sentences, this diamond shapes, are taken from the records. Exactly the clue and answer. Somali clue, young Somali refugee with painless hematuria. Think about the schistosomiasis until proven otherwise. Eosinophilia rule, African patient with eosinophilia. First rule out malaria. If the patient is febrile, then schistosomiasis and helmet. Cancer type in schistosomiasis, the patient will have a squamous cell carcinoma of the bladder. If there is a smoking history, then think about urothelial disease. And calcification, bladder wall calcification in ultrasound that can show the chronic case of the hematopia. Okay, this is transitional cell carcinoma. Now, some differential diagnosis with the bladder cancer, hysterangolidosis, malaria, urethric stone, renal TB. With the bladder cancer, the patient will be old, long history of the smoking, no eosinophilia would be there, and investigation is cystoscopy, and you will to do for we do cystoscopy for urothelial pathology. The management would be oncology surgery, and the AMC thing choosing smoking as cause in young African migrants. Hysterangolidosis is primarily GI symptoms with eosinophilia, and investigation is hysterangoliditis in serology or stool agar culture. The management is we will treat the patient with ivermectin. The ANC trap is confusing all eosinophilia for schisto. Because eosinophilia is also in schistosomiasis and hysterangoliditis as well. But the main point here is primary GI symptoms in hysterangoliditis. Malaria case, high fever, cyclic chills, splenomegaly. The investigation is taken in blood film, is gold standard management is artemether lumefantrine, and ANC trap is testing for schisto before excluding malaria and febrile refugee. Urethric stone, the patient will have a quadriculoine to growing pain, no eosinophilia. Investigation is non-contrast CTKUV. Management is analgesia, stone management. AMC trap is missing travel, eosinophilia clue, and treating as a renal colic. Renal tuberculosis, thrill pyuria, constitutional symptoms, weight loss, night sweats. Investigation is urine TB culture with 6A, and the management is long-term, 4 drugs, quarter therapy, and AMC therapist, both cause hematuria with calcification. First check pulmonary sign and BCG. Now the pitfall and traps again: malaria trap, smoker trap, asymptomatic trap. In malaria trap, malaria must be repeated more than 3 times if clinically suspected before switching solely to schisto investigation in a febrile patient. Think first about malaria, and after once you rule out this, then go with schisto. Smoker trap, old Somali man with the smoking hematuria, look for eosinophilia. If eosinophilia is present, think about schisto. And asymptomatic Travis, asymptomatic refugee with a high eosinophil count still requires serology for schistosomiasis triangularitis to prevent long-term complications. Some must do and do not do table. Ask about the freshwater swimming in endemic countries. Check for peripheral eosinophilia in any migrant with hematuria. Treat with praziquantel if diagnosis is confirmed, and check the renal function, urinalyze and electrolyte. Chronic disease causes post-renal acute kidney injury. These all should be done, and they are must. Do not exclude schistosomiasis just because stool microscopy is negative, and assume bladder cancer is urothelial and endemic region patient considered squamous cell. Treat with antibiotic alone if a bladder mass is found in patient from Egypt. And forget to screen for co-infection, hepatitis B, C, HIV in refugee. It's not super important, but just to know. Now some recalls. The recalls case stated a 41-year-old Somalian recent refugee present with painless hematuria while urinating. So the patient got a painless hematuria while urinating, and also patient is a refugee, most likely diagnosed schistosomiasis, ureteric stone, or bladder cancer. Here we go with schistosomiasis until proven otherwise because this is a refugee and painless hematuria there, which is a clue for schistosomia hematobium. It's a chronic case and aches, deposits in bladder walls, chronic inflammation that can lead to terminal hematuria and ureteric stone. We not go with that because there would be a colicky pain in the scenario, and the patient for bladder cancer should be older and a smoker. Now, none of those in this scenario. In March 26, a man recently came from Africa asymptomatic. Eosinophilia is 2.4, 10 power 9. Malaria test 3 days ago was negative. LFT and examination is normal. What is the next best investigation? They ask about investigation. In this case, they give immunoglobulin A or RAS, leptospirosis serology, repeat malaria, again, stool O&P or schistosomiasis serology. So the correct is schistosomiasis serology because this is a symptomatic case, not a febrile malaria. Repeat, not priority because that's been already ruled out. Schistosomiasis serology is most sensitive for chronic asymptomatic case and is a standard in Australian refugee health protocol. So now the next recall in June 25, African refugee routine check fever and splenomegaly. Fever and splenomegaly, African refugee malaria test is done before leaving was negative. Now asking most appropriate next step, repeat malaria test, secantine film, schistosomiasis serology, filariasis testing. Why not here schistosomiasis serology and repeat malaria test again? So here says the patient is febrile traveler from endemic zone. That is one point, which can make the malaria emergency first. Must repeated tickentin film more than 3 times over the 12 to 24 hours. Schistoserology is for your routine check, not a priority then when it is febrile. In this case, there was no fever and the patient was asymptomatic, clearly said. Okay. And also no hepatomegaly or splenomegaly problem, only refugee. That's why this is the difference, how to go stepwise. So there is, in the recall, sometimes they are giving you a very small hint and clue. If you find it smart enough to find it, you will answer it correctly. Otherwise, you will feel in between schistosomiasis, malariasis. because these two are very quite near to each other. Okay, this question is painless hematuria. Okay, so now the next question. Africa refugee again for medical check. Malaria is tested. Antibiotic prophylaxis given pre-arrival. What else should you test for as a standard protocol? Schistosomiasis, stool test for a protozoan larva. Here we go with schistosomia because the seven guidelines mandate the schistosomia serology for sub-Saharan African, and many are asymptomatic with chronic infection that cause long-term complication if they remain untreated. Okay. Dr. Larib, fever and traveler, we will consider malaria. Yes. For fever, I agree with you. Traveler can be in schistosomiasis and can be in malaria in both. But see if it is asymptomatic, and in the scenario already, in each of these questions, while we go with schisto, already malaria tested several times and that came negative. This means malaria is always priority and then schistosomiasis. Because in the exam week, the recaller bringing the question and we answered this as a schistosomiasis because of the given information. But once you go to your exam, look around this information like asymptomatic, fever, splenomegaly, or if there is painless hematuria and still it's a refugee, which points you have to look for, right? So this way the AMC is changing minimally this scenario. The scenario will be totally same, only they adding, for example, fever, or they adding splenomegaly. And the options will be also same. Okay. Now there is some revision summary. Organism for the schistosomiasis is schistosoma hematobium, on which the patient will have urogenital disease. And if the patient has a schistosomia mansoni or japonicum, then the patient will have some hepatosplenic or GI problems. Transmission is through the freshwater exposure and penetrate by skin. And the key complication, the patient would have bladder wall calcification, squamous cell carcinoma of the bladder. Trigger phrase is painless hematuria, refugee, Africa. Think about schistosomiasis. If again asymptomatic patient is eosinophilia with Africa traveler, think about helmet screen. Screening serology is first line for chronic or asymptomatic cases. And then we go with the urine stool microscopy for AIDS, and then we go with ultrasound CT for bladder wall to find out the thickness. The gold standard management is parasequential. Immediate question, 41-year-old Somalian refugee painless hematuria. Otherwise, well, most likely diagnosis. This we done in the recall section. And again, this question, 28-year-old aid worker in PNG. Okay, so 3 months recurrent fever, lymphadenopathy, bilateral leg swelling, eosinophilia is 2.5, 10 power 9, and non-pitting edema, thickened skin, enlarged inguinal nodes. Most likely diagnosis, thrombolytitis, lymphatic filariasis, schistosomiasis, or Lovasis or onchocerciasis. This is a lymphatic filariasis because this is a bilateral lymphedema in PNG. What is PNG? Bilateral lymphedema. Oh, okay. Papua New Guinea. Huh? Okay, the bilateral lymphedema, and the patient is Papua New Guinea, and the patient, can be lymphatic filariasis, elephantiasis, and in the case of schistosomiasis, cause hematuria or hepatosplenic disease, it does not cause bilateral leg lymphedema. Okay, so non-pitting edema with thickened skin and large inguinal nodes, and lymphadenopathy, bilateral leg swelling. So these are all making sense for lymphatic filariasis. The next immediacy X-ray showing calcified abdominal fracture in migrant, most likely organism. Calcified abdominal E. coli, Mycobacterium tuberculosis, Leishmaniasis, Schistosomia mansoni, Wuchereria bancrosti. I don't have the picture, unfortunately, but they went with the Mycobacterium tuberculosis here because of calcified lymph node. If you guys can check the immediacy if you find this question, that would be great. Or otherwise, let me check this in immediacy. Okay, so we move on. Mycobacterium tuberculosis, because there is a calcified lymph node. We move on, and I will bring back the picture. Now here is some summary point. Classic triad hematuria with the xenopedia with the travel Africa, Middle East. Think about the schistosomia, pathognomonic risk is freshwater, and the schistosomia hematobiome. The patient will have urogenital problems. And for the Manzoni, they will have hepatosplenic or intestinal problems. Treatment is planned, etc. Just one sec, I think I found it. Okay, so this picture given, and so the complete question is this. It says a 30-year-old woman who recently migrated from India present to the GP with 3 days history of the crampy generalized abdominal pain diarrhea. She has no significant medical history and takes no medication. On exam, she appears well with vital sign normal. Abdomen is soft, mild tenderness in the left lower quadrant, splenic phase performed. And these options were given. And the answer was given as the Mycobacterium tuberculosis. There is good information there. Let me attach this as well. So the clinical manifestation of abdominal tuberculosis depend on an organ involvement in intestinal tuberculosis can be abdominal pain, distension, diarrhea, nausea, so the vomiting, constipation, bleeding, and this patient recent migration to India, drug-resistant tuberculosis should be considered as a drug susceptibility testing. Previous exposure to tuberculosis commonly caused by lymph node calcification and abdominal X-ray. Abdominal tuberculosis affecting 11 to 16% of patients with extrapulmonary tuberculosis. Recent migration, high burden countries should be assessed for drug-resistant tuberculosis strain. Why not this schistosomia? Because here they say that infection can cause calcification, but these are typically seen in bladder wall or ureter rather than lymph node. Only lymph node can make this different from the schistosomiasis. Okay. All right. So let's move on to the exam trap. The stone trap. Choose ureteric stone for refugee with hematuria. This is a trap. What the exam tries to trick you and how to beat it. Stone trap. Choose if you're choosing ureteric stone for refugee with hematuria. How to beat it if in this stone case there is eosinophilia and freshwater exposure, so go with this schistosomiasis. Cancer trap confusion schisto with the bladder cancer and older migraine. So bladder wall calcification go with schistosomiasis. If there is a heavy smoking history as well, go with the urethria. TCC. Okay. TCC is transitional cell carcinoma. Albendazole trap, assuming albendazole cover everything. But think for persistent eosinophilia after failed albendazole, think about schistosomiasis and give the patient praziquantel. So this topic is covered. I hope that you guys learned something about schistosomiasis. Now the most important topic came in last 2 months, dengue fever. Let's have a break, doctor, and then we will start dengue fever uh, quickly with the other two topics as well. Okay, so let's have a break and to fresh ourselves, then we will be back.